How has the system, so the system as a tool, how's that really sort of supported you working with your athletes? So I guess first, Sue, tell us a little bit about your athletes.
So I have my cheat sheet here that with things that I jotted down.
Sure.
So for me, I use it every day for every kid that I see. They're kids because they're like 18 to 24, 23. So they love it. They love getting the text message. In fact, if I see someone and it's maybe, I've treated them and I haven't gotten to sending it yet, and they see me, they're like, hey, am I going to get that like so-and-so got? So they really like it. And they like the video and the instructions because, and also for me, it's such a great record of, I can see what we're doing. I can see the exercises. So I really enjoy it. The one thing is, because I'm always, like everyone who treats, is pressed for time. I usually end up just picking 2 or 3 that sort of seem pertinent for that particular issue. And then I might add something like more as I see them, because I'm like, So, but in that first session, I'm probably focusing more on, just that particular joint. And the rest of the body, of course, I'm focusing on, but, I still have to evaluate the injury. And so you have even less time, because we see acute injuries, because we triage and send to the physician. Physicians come to our facility. So you're also evaluating what you're seeing, so that obviously you're, somebody has a stress fracture or whatever, torn ligament. But so I don't always have time to do, I rarely have time to do that much. But as they come see me, I often do more and more. And as they start to get better, I do more and more when they're more functional. So
to just put this into context then, so you're working with collegiate-based athletes, and we've got multi-sports, we've got a whole range of different sports we're working with. We've got male, females, and we're identifying that time is sometimes quite sort of precious and pressured. So therefore, that we deliver our testing, we go through the TPM system testing, and then we're sending out retraining interventions through the exercise catalog. And typically, we're only going to sort of focus on a few of those initially, but as they become more familiar, as they improve, we start to add to that. So that's a sort of a summary where we are so far.
Yes.
Okay. So I'm going to then sort of dive a little bit more into the testing specifically, which is this sort of next question, which is what do you feel, or what do you see as a sort of TPM offering that I guess you haven't found with other ways of testing? Is it simply just it's different, it shows you something different? I mean, what's that comparison like?
For me, the reason I really like it, and the more I do it, the more I like it, is sometimes I don't know where to start with someone because they have so many issues.
Okay.
And it can almost become overwhelming. And so the test sort of, for me, have me focus like, okay, this is the most glaring, this is what we're going to start with. You can't control, medial rotation, and your tibia isn't moving. So I'm going to focus on this right now. So we're going to focus, say it's a knee pain patient. And, as I treat, I'm because I'm going to look at, you know, the range of motion, hip mobility, blah, blah, blah. So as I treat, I'm going to go ahead and, you know, look, I mean, some of the tests look at lumbo pelvic control, but I might like add a couple more as we go, because I feel like that's a bigger issue than maybe I thought from the other tests.
Okay. So, I mean, what you're identifying there then is it's when you presented with anybody, I guess there's where do you start? And in some cases, it's very challenging because of the number of different issues that could be present. And then I guess the systemized process of TPM offers you a way to sort of navigate through this, and at least at the end you get a report and go, well, I can prioritize from that list now. As before, it's sort of, where do I begin? Having talked to another sort of practitioner of this, they say what they also get from is it means that I don't miss anything, because you have a battery of tests. You don't instantly get drawn to, oh, that I think that's the main problem, I'm going to just focus on that. You don't sort of miss something else out. So again, do you feel that sort of, could you relate to that scenario?
Yeah, that's perfect, because, you know, it's often now I'm like, okay, one exercise, like an exercise that gets lumbopelvic. And you said this in the course, but of course, when you're first, you know, learning sort of a new system, you don't really get it. But so, okay, I want pelvic control, I want hip stability, you know, so I want to work on motor control at the knee and them managing their tibia position. So yeah, so that's, I mean, but I might say, oh, I'm going to take one from this category, one from that category. And it's very easy to know like what exercises to give. And at first I was, when I didn't really understand quite so much how to really hone in, and I'm still learning, of course, but on the site direction, you know, I may have been like overwhelmed, like, ooh, what exercises should I give? But now it seems much easier, like, no, this one will do 3 things. And that's all they're going to tolerate right now. And so, like, it's easier for me to just give 4 or 5 exercises, because I always have to give people like foam rolling or stretches, because they're so, you know, they're so dominant in the multi-joint muscles that in athletics that, you know, they can't, if we don't do something like that, especially when they're not around me, I don't think they benefit to the same level from the exercises.
You've introduced some really nice terms there, and you've talked about the site direction threshold model, and again, presenting it in that way, as in identifying there is some sort of issue, and I guess how the system presents it within the report is site, direction, and then threshold as a profile. And again, how do you feel that sort of supported your reasoning with the athletes there? Use of those 3 terms.
So for me, it gives me a better framework to explain to the student athletes why I'm doing what I'm doing, and to not demonize any, like, your multi-joint muscles, or that they're not important, or that because I'm saying that it's tight and doing too much, that's a good or a bad thing, a judgment. And so, and they need that because they don't understand. And so it gives me a way to explain to them, like, these things are both important, and we're going to circle back. But fortunately for me, I do a couple high thresholds with kids, but often, like, I'm going to throw them in and tell the S&C guys, like, could you do like a plyo progression where they're just starting with pogo hops and things like that. That way I can see more kids, and I'm not spending a lot of time with doing too much of that. But we usually talk about, like, this is what, like, I need them to do in this range of motion, and they're terrific at it. And then they add their own suggestions for me. There are some times where I have to do more of that stuff, but most of the time I can use their assistance. And I definitely focus more on range of motion inhibiting a lot of the overactive muscles, and
we don't lose the foot into pronation. If I ask them to, they can show me those different choices. I guess how would be describing this stuff. And I think you're also talking there about the sight and direction threshold as a tool to help the interaction with other professionals. So you're talking about the S&C coach and how this sort of framework is, you can sort of work alongside them, and that's maybe a little bit more seamless than yeah. In some scenarios, I know that's a bit of a challenge. So it sounds like that model's helping.
Yeah, I'm fortunate at my facility. We get along great, but I always tell them I can't return someone without your help. And sort of that importance of understanding, you have to reestablish that the idea that those high threshold muscles can't work as stabilizers. They have to work as, dynamic, fast twitch muscle fiber. I try, sometimes when I use the words high and low threshold sometimes, but some people, they're still, what does that mean? Like they don't exactly, the people around me all the time now know, because they're probably sick of me hearing it, but because when I work with the kids, because I want more adherence, I try to explain to them what we're doing, because I feel like it helps.
If I mean, one way I've thought about explaining this again, if you've got athletes who are in an academic process, and if they get exposure to force plates, so the fact it's on a force plate, you've got you can change the sensitivity. And what I'd be saying to them is, well, on a force plate, if you want to detect a very subtle movement, you've really got to turn up the sensitivity of the force plate. So this is similar to a low threshold scenario when there's not a lot of proprioceptive input going on, but the individual needs to be sufficiently proprioceptively sensitive to detect motion happening. Whereas high threshold, actually, there's a load of stimulus, and yeah, it's challenging in terms of fatiguing effort and force production, but it's easy proprioceptively, as in you can sense the movement much more. It's much more pronounced. So I think that's one way to describe it. Certainly, if people do have some exposure to force plates, because they okay, I've got to sort of turn this thing up and down. And low and high threshold, to me, that's how I explain it in my own head to myself. So that's good. That sort of exploration, and I can obviously hear that you're sort of educating those around you about those sort of those terms as well. The system within the test, and this is how is the sort of the principles of retraining that we sort of cover within the course, within the performance solution element. How's that sort of, or has that affected your own sort of exercise design and delivery within other exercises? So not even within doing this specific retraining, but has it inspired or sort of helped with other exercise delivery?
Yeah, I think for me, it's like more of the understanding what you're training. Like, okay, and my staff, and most of them are young, but everything they give the athletes, they're throwing a band on them, which there's nothing wrong with that. But it's that same thing is whatever you do, just know what you're doing, and what your outcome is. So, if somebody is so inhibited that they can't use their posterior glute med and you're slapping a big thick band on them, they're probably still using their superficial glute max. So just know what you're doing. If that's what you want to get is superficial glute max, I doubt, but
yeah.
Right.
Yeah.
So for me, I think it's helped really focus on that. Like there's nothing wrong, and you might use a light band for someone because proprioceptively they need that. But there's a difference between a light band, but my goal is, can you actually activate your glute with your body weight, just your leg or whatever, which is normal function, right?
Okay.
And then progress from there, right? The difference between high and low threshold, and understanding like as you say, the shape, and you're not just getting that muscle in that exercise, you're getting them in a lot of the exercises we're doing, standing, sit, right? So that's a little more focused, open chain, getting sort of starting that, having your brain start to recruit that muscle again. But because some people need to do. I found this, and how many kids that are doing super high level things have to start super low, like with exercises. You know.
So that mismatch between, I guess, the task they're aiming to perform in the sport and how that's been done, but also then how they're moving around the planet the rest of the time. There's a bit of a difference. The notion of threshold allows us to differentiate that. You've also mentioned there this you might use some load facilitation with a band to help sort of help somebody recruit a muscle more. But as you say, there's a big difference between doing that and then trying to fatigue out a structure. And then awareness that the more load you're going to add, you're going to get a sort of a change in which muscle synergies you're going to place bias upon. So again, a good sort of feel for that is important. So that's good. It's sort of flowing into other areas in terms of exercise design. The Performance Solution course then is sort of what individuals coming into the TPM system would go through as a piece of education, and that's all sort of online as a piece of e-learning. Again, how did that sort of support you getting through to the point of I can now test somebody and deliver retraining in the real? So how did that education support that process?
You know, I think for me, and everyone is different, I really benefited from, like, sort of after I did that, when you guys put on the hamstring demand share course, because I kind of saw you sort of put things together and then use the shapes differently, because giving something to brace their knee against or things like that. But and I think it focused more on the shapes and how you can, you know, transition high, low. So for me, it was like this putting it together in practice. So okay. For me, I feel like I needed that, like, oh, okay. And then it was like, but you know, you say that, but in general, in your learning, like, you can only learn so much at one time. And there was a lot in that course. And I went back several times and I would rewatch it. But I felt like I did need more about, like, okay, this is sort of how you could put it together here. You know, this is, like, which seems more mechanical, but in the beginning, it's kind of how you learn before you can just be like, oh yeah, that also, and you would say things like that in the course. But it was like, okay, well, what would a program look like? And then you had an actual person that they used as like a case. And for me, that part was really helpful about just seeing it in action, kind of a thing.
Yeah, how it all comes together is so great concept, principles, all the things you could possibly do, but actually what do you do with it? And that being presented within a case study type program was, I think, yes, always very useful if we're delivering that face to face as well. And of course, with online, I guess you don't have that instant ability to always apply it with somebody. So yes, I appreciate that. That's and that was great that it was sort of reinforced then with what we did with the hamstring content. Okay, so we've talked about sort of a fair bit about sort of TPM. Then I'm going to sort of just touch on kinetic control. So kinetic control then is, I guess, the original sort of Chimera movement science range of courses for clinicians, and it's been around sort of 25 years or so. So I know you've attended some KC events now, some education events, and one of those was the restrictions course. So again, how was the restrictions course, managing restrictions with Mark? And again, how has that influenced your practice?
For me personally, it was like a kid in a candy shop where he's like answering all these questions or all these things like that you used to think like, God, how come this doesn't work? Or why is this like this? Or why isn't this like, so, you know, and I keep going back to, and it really made me realize, like, you know, obviously that's just, there's all these courses that really like how much there is to know about these different areas, and that, and I get that, you know, I've taken a lot of courses, but in a much different way. I enjoyed also sort of the academic piece, that it was, the material was really like thoughtful, researched. It wasn't just like, there are courses out there that sort of morph they try to say that it's like this or that. And I don't want to, you know, judge that, but it's not based on like real science or physiology or biomechanics. It's just their theory, and they're trying to cherry pick the literature, but it doesn't really fit. But so I really enjoyed that, because it's sort of my personality, and I think in my population everything has to be evidence based right now, because it's just, they're young, they're students, they're impressionable, and we really want to make sure that our standard of care is high. And I feel like that all the courses that I've taken from you guys are really quality. Like, you guys care about content and how it reflects the literature, and sort of what's going on in this realm with other researchers and things like that.
I mean, we're very fortunate to have that part of the team. So Mark and Sarah have both come through an academic process and are still involved in that. But also because they've been very experienced clinicians, we've got this sort of mix of based in evidence, but also based in sort of clinical expertise put together very well. I think Mark is especially good at sort of evidence-led practice, as in knowing enough that you can sort of construct it together, going, well, I can apply it clinically like this, coming from all these different sources. And I think what we get with Sarah is more sort of research to back that up. So that's it's a very good mix within the team. So that's great that it comes through in the education, and that quality is there. So that's really important to hear. And you've sort of talked about Mark there, and I think we were sort of talking about his generosity of giving with respect to his way of teaching. So a little bit of background is, I know the course you did with him was you've done managing restrictions, and I know he was teaching. He started the course at midnight in Australia on a few consecutive weekends, and delivered sort of 4 nights of education for 6 hours. So yes, it was quite a challenge. So again, how was that experience of sort of working with Mark on those courses?
It was terrific, and I have to say I love the online, because you can't remember all that material. I don't care if you write it down or what you do with it, you cannot remember it. And you know, of course there would have been some things to do live, especially like when he was doing like the cervical and thoracic, but you know, like the ankle, all that stuff that's a little easier, you know. And actually for therapists, I'm sure that do a lot of spine stuff, that wasn't hard. That was like, oh, okay, that's, you know, but for me, I love being able to go back and look at it like, okay, like maybe I have a patient and I'm like, oh, okay, let me like look at that again and see how he positioned. So I love the fact, and I thought, wow, that was so nice that he added that content at the end, like an hour. He went back because we didn't have time. I don't know that many people would have done that. They would have just said, hey, it's in your manual, thanks for coming. So I thought that was terrific. But the other thing for me is sort of this, you know, sometimes you learn things like, oh, I learned exercises here, I learned soft tissue techniques here, I learned mobilization here. Like, everything is compartmentalized, and I felt like he did a really sort of good job. Like, even during the course, after, you know, you would talk about a muscle and the implications of its tightness, you would then talk about, strengthening sort of the high threshold, and also like, what do you have to stabilize? Like it kind of was like, in athletics, everyone has restrictions. It's like, if they don't, it's shocking. They're probably not participating in a sport at that time or something. But so I thought, and saying like, yeah, you gotta like work on this to get to this, but it sort of like gives you permission to understand like, okay, it's a blending of everything sort of you've been learning. Like, yeah, stretching isn't necessarily new, foam rolling, but it's like, okay, but you're going to put it all together and treat this patient. And maybe you were doing that before, but sometimes when you take a course, you just like, oh, just exercise. Well, they're not getting better. This doesn't work. Well, it's not that it doesn't work. It's just you got to address other things with it, right? Like, it's not working because, they're stuck in inversion, or they're so tight, in such an anterior pelvic tilt. Like, you have to address these things. And even though sort of, I think if somebody told you that, you would know it. Knowing it, doing it, and understanding the details are miles apart sometimes.
I think there's a lot of tools out there. There's a lot of exercises and stuff and approaches you can do. I think what I see within the CMS way of doing things is you get everything for a reason, and everything sort of tied together. That, well, this is where this bit fits in for this reason, as opposed to here's some stuff, which again, a bit of a blanket approach. I mean, that's okay, but how much time you got? And sometimes you might be doing things that actually go in the opposite direction to where you want to go. So what I see with it is it gives everything a purpose, and yes, including the restrictions content as well, and how that sort of fits alongside. I guess what you get with TPM is these are the bits that you can't stop happening. These are sort of the choice you've lost, and you can grade that by sort of high and low threshold. With the restrictions, these some of maybe the drives about why those things were there in the first place, and those things have got to work together. We got to address both sides of that. So okay, so lots of content in the managing restrictions course. We're going to be making we're going to turn that into a course in its own right. People will sort of go and get as a ready-made sort of webinar to access, and it will stay sort of as content you've got already.
Yeah, and I think honestly that no matter, if the TPM has so much content, it's funny, you take another course and you're like, oh, that would be good if I would have known that. And then you're like, yeah, but it was already like so much to understand. Like, I needed to understand sight and direction and a lot of the stuff taught in that course to really like benefit. And I had been doing it from the restriction course. Like, that helped me to understand that more. And some of in the tendinopathy course that he taught, like, it's just like additive, right? It's not like anyone could teach one course and all of a sudden, like, you could take all that in and actually use it. That's impossible. So I do think that suggestions like, hey, this is a good one to take after, or, so for me, like, all the courses I've taken, I feel like just enhance my understanding in the next course that I take. And I do feel, for me, that I learned so much in every course, that there's not like one course, like especially the TPM, because it was like the intro. And I had to have that, and I only was starting to understand it as I took more courses, and then it really helped me understand it more. It wasn't like, oh, you just take this and then that's it and you understand everything, right? And it wasn't designed that way. But having those resources when somebody's done, when they know that they need to learn more, having those resources online, at least for people in the United States, I think is tremendous.
Okay, so that evolution then of the education was, we did the Performance Solution TPM course initially. We did then the Hamstring and the Soleus Dementia content. tendinopathy session with Mark as well, and we've also got the managing restrictions course. And you're saying that they all work together. They're different, but there's a common theme throughout. In terms of the demand share content or the tendinopathy, then again, how have they been able to sort of come into your everyday? How have you sort of applied those with your athletes, some of the content from those courses?
So, what's nice with those is that they put everything together. But so for me, it was like, okay, step back. What are you thinking about? You have a hamstring. What are the other things that you need to do? And there are there's a lot, like Asling's work and Born and who's the guy who developed the Nordic machines? What's his name? David Opar, yeah. So there's a lot of people out there, and all of the guys that did their PhD, Jack Hickey and Born and all those with him that have put out great things, but it's always just predominantly a hamstring program. And Asling's, his well done, and he's meticulous about his cohort was homogeneous. And for me, that's kind of fun. Oh, he just has soccer or track, and well done. But it's pretty much just hamstring. So for me, it was and I know there's other people out there and they probably also may use other things. So I'm not, but just seeing a program when they're talking about hamstring to say, yeah, you could do all that, but you need to also think about, the calf and, the adductor magnus. Sometimes your brain falls out, somebody gets a hamstring and you forget pre-existing injuries and all these other things. And you could have been doing them, especially early on when they couldn't do any high level things. And, you could have been working on, soleus and posterior tib and peroneal brevis work and tibial rotation to give them all that as they progress. Because I have a kid that has a distal hamstring now, and she had in high school torn her ACL, but her tibia was it hasn't probably moved in a year. So I can't totally I can't progress her to high level hamstring stuff if she can't even because she has to go into valgus so at her knee. And so yes, she was running and she's actually a good runner, but it really made me think, I think of the course, they pulled their hamstring, but and you will get to that, but you need to also look at make sure that why they pulled their hamstring isn't going to come back to haunt me, so which makes it slower in some ways and faster in other ways, right?
Yeah. I think if we talk about hamstrings, and the focus of the past 10 years has been very much on the force production qualities and the eccentric qualities of the hamstrings, and a lot of just attention on the abilities of this one structure to produce some sort of outcome of typically force production. But then if we remain just within that one space, then we tend to not address, as you say, those other force production related issues that could be coming from a calf. So joint propulsion in running, there could be other factors at the hip that might mean that the hamstring is doing a whole load of work and is going to become recurrent because of this. Yeah, there's the need to address the issue at the hamstring, but there's then also need to be sort of thinking a bit more broadly about other reasons why this is coming back in the first place and sticking around as well. Yes, hopefully the hamstring research will become again, I guess, more expansive in its take on looking at other things than just sort of force production, eccentric force production. It's good stuff because it's going to be in the picture, it's going to be in your program, but what else is in that program too? Okay, so overall then, what is it you feel is your sort of next next progression with the use of the system yourself? What is it you want to improve with your athletes, specifically for yourself, as in which skill or ability or an understanding? What do you feel the next sort of route progression is?
So I really, in the restriction course, I really liked the when he did the, went into sort of more some of the manual stuff and and I know it was, not in person, so it was hard to really, but I feel like those things like are the parts that, like my staff wouldn't look at. And you know what, in the past I would look at it, but probably not in the same ways, or I would try other mobs and they would, but everything was so like, you do it and it works. Like, because there's a million joint mobs that you can in courses, but I really liked like it works. I mean, and
It's
in
a good
my
outcome.
yes, and in my cohort, they're young, so I'm not getting degenerative joints and things where like they'll improve, but they're not going to like an arthritic hip isn't gonna like maybe get back all their flexion. Maybe they'll get a little more back and you'll really help with their pain, but you're not gonna change a degenerative joint, right? So things like that, but I don't really have that in my cohort. So, but treating the mechanics sometimes is like, it totally like helps with their pain, motion, and the exercises go much quicker. And so for me, that would be fun to be able to increase my skill set so that I can be assured, like, okay, here you go, here's your exercises, that they work, and they're not working because you have a restriction, either articular or myofascial or something like that. So, some of the maybe spine or shoulder and stuff I think sounds super interesting. I really enjoy it, probably because it works.
That's a really good outcome if you get to see it working and it works within a short amount of time as well, and it's very builds good compliance for all parties there when they start to see things actually sort of changing. And again, if you've got a cohort that maybe needs that sort of faster impact from what you're delivering, then that's going to be important. That's very valuable. Okay, just then thinking, any sort of final thoughts then in terms of the CMS approach or the CMS way of doing things? Any sort of final thoughts there?
I do feel like it's a lot and it can be almost overwhelming. Like for me, the TPM was for sure like a really nice segue. It was like and I've taken a course before, but it was so long ago. And it's not that I think because of the way they teach the courses, but I really like the TPM because I liked that sort of bigger picture, helping people be active, because I really believe in that. And I do think that there's a lot of people, even if that still benefit from that, even if you can't give them all that. There's plenty of people, athletes overdo it and do everything to fatigue, so it's a little bit different. But so I really like that. But I think as you the more you learn and that you see its benefit, the more you want to learn, kind of a thing. And I know learning, there isn't an ending to it, but I think there's a good grasp that helps you to move forward in your, there's been all these things about clinical reasoning, but you can't, you need the knowledge and the experience to be good at clinical reasoning, right? Like if you don't even know to look at the restriction, how it doesn't work that way, right? So I think when people, you have to get the knowledge before you can start to really be good at clinical research or at clinically like evaluating a situation and looking at it. And I think that TPM, the site direct, like it's like a clinical reasoning piece, right? I mean, it's making you have to think, which I enjoy. So, but with that, like, you know, before I've taken all these courses, my clinical reasoning was much different than it is now, right? Like, it's much better, and I wanted to continue to improve, but you can't just read a paper to get that. It takes like, take a course, use it, like, oh, get stuck, take a course, use it, gets like, that's just learning, right?
And if you summarized, when you say your clinical reasoning is better now, if you summarize why that is, what would you say is the answer to that?
Because I think you see the full picture better in that, you know, not that you don't think all these things exist about neurodynamics and articular structures, and but you don't know enough about them to understand what it would look like if you had a restriction. Like, what would it look like? What wouldn't you be able to do? You know, we have students, and the thought of the tibia, mobilizing the tibia, or the tibia not moving, like, and its relationship to function, to them is like, you know, wow, really? And its importance, you know, so for me, I'm going off on a tangent like usual here, but I think that I can see more of the moving parts and how it affects it more specifically, like with the details. I always say the devil's in the details, but you don't know that until you know enough to know what you don't know. And it's like, that's, you know, my journey, like trying to continue to understand, like, not knowing what you don't know. And, you know, I think every course I've taken, I've been like, oh, okay, yeah, like I didn't realize that, or I've never heard it that way, or I've never, you know, like some things you've heard of, but you didn't really understand fully about that particular thing. And I think even in the restrictions course, something as simple as, you know, and you know all the ways that you stretch a muscle, but why do you use that way? Why are you picking what you're picking, and why would you not pick it? You know, why would you choose to not stretch someone's groin with anterior hip instability, right? Because you didn't want to flare them up, or, you know, or would you, or what would you do instead, or things like that. And to me, like, if you don't even know it exists, or how to even assess that it exists, you can't, you know. And I think that's it. And I see that all the time, and I see it like at every level, right? It's like trying to know a little bit more so you could add that to your evaluation and the way that you interpreted the injury and the body and what they have to get back to. And there's all these layers that you need to, like, if you could learn a little bit more, you'll be a little bit better at your clinical reasoning. And so to me, to take a course on just clinical reasoning, for me, if I don't have the knowledge about that area, it's not as helpful. If I have all this knowledge, then, you know, then it's easier to take a course on clinical reasoning. But I don't know, if I don't know enough, then, you know, I'm going to draw the short straw.
So there's the layering of the content, the understanding of the mechanisms and the principles, and then putting that together within a clinical reasoning approach and package for each individual. All right, there's a lot of good content here. So I'm going to sort of say I'll let you get on with the rest of your morning there, and what I'll do is I'll go through and edit the content, and so we've got something we're sort of really sort of good, clear story about where we're going. So one thing that we've got coming up is this intro to KC content. So have a look out for that, because that might be a bit of a sort of an overview of all things in the box of KC, and so that might be interesting. So yes, I'll say thank you for your time this morning over there.
Yeah.
Is this so is it breakfast now, or is it you can sort of are you working from home today? Can you go into the university or not today, or is that?
Yeah, no, I do both. I do a little from home, because when I go into work, it's basically just treating people, so I don't get anything else done. So I do a little from home, and then I go in to to work. So I'm doing both now. So yeah. So, and how about you? Do you?
Are coming along.
Yeah, I would love it. I love it. Yeah.
One thing that's going to go into the TPM accounts very soon is the TPM Express, and that's the short screens, the eight short version. So you're going to have the base and the foundation split in two, and also upper quadrant, lower quadrant, low and high threshold. And each one of those got 4 tests in. So that should be a really quick, short way to do some testing.
Awesome. Thank you. That'll be exciting.
Yeah. So that's just about ready to stick into account. So we're quite pleased with this. So, all right. Good. Well, I'll see you later for now, and catch you next time.
All right. Take care.
Bye-bye. Bye-bye.